the region of knee. Second biggest joint of the human body after the hip joint, but functionally it's much more functional comparable with the hip joint region. Approximately 30% function is more in the final movements of the human body, yeah, because you understand that in the mid joint, possibility of the movements is more than in the hip joint. Hip joint is working the four main, we can say, planes. Mid joint in six. Let's say from that point of the view, of course, functionally it's much more important kind of the joint for the human body. Traumatization is very usual. I want to say that approximately 20-25% of all lower extremity traumas become to the region of the knee joint. Which kind of the traumas of the knee joint you can see? First of all, of course, it is the soft tissue traumas. Different kinds, I don't have now time to speak about it. But inside of the soft tissue problems, guys, there are specific disorders which is connected with the ruptures of the different tendons and different kind of the soft tissue structures which we have inside of the knee joint apparatus. You know, here we have the ligaments, here we have tendons, and of course the rupture of them. After in the future I will explain it, I will show it for you. But now remember, please, that can be impossible, or it can decrease the functionality of our joint. That is one. Number two, it is the cartilaginous structures. We have here, for example, the meninges, which is covered by the cartilages. Generally, the surface of the joint bones is covered by the cartilages, and we can have the ruptures, we can have the fractures. Triangle in the region, fractures generally we use for bony structures, yeah? But anyhow, for the meniscus also we use this terminology, but meniscus is not a bony structure, it is the cartilaginous structures. So we can have the ruptures of the meniscus, yeah? Which is also can make it possible, can make the block of the work of the joint. Let's say this is also critically important. Let's say soft tissue problems. It is the ligaments, it is the tendons, inflammations and traumas of synovial bursas. This is also important to mention. Yes, usually in the region of the joints, we have the synovial bursas, which is meaning, for example, protectional effect, decrease the friction between the structural units. 7 synovial bursas we have only in the region of the knee joint. As you remember, the inflammation of these structures we call bursitis. And in the future, you will see that one from these 7 bursas has communication with the knee joint. In that case, of course, bursitis can be developed into arthritis. This is important to mention, guys. Little after I will speak about it. Keep it in your mind, remember. And finally, of course, last but not least, it is fracture of the bones. Fracture of the bones, I want to remind you that 4 bones involve information of this joint. From upwards, it is our femoral. Bone. From downwards, it is 2 bones, tibia and fibula, and patella, which is located in front of the knee joint, and which is making the protection of it. Let's say all these mentioned structures can be damaged, and we can have the bony fractures. By the way, fractures will be divided into 2 types. So-called intra-articular and extra-articular, means fracture inside of the capsule of the knee joint and fracture outside. You usually remember, guys, any intra-articular fracture treated strongly by surgical performance. This is very important to mention. Why it is important, guys? Because if it is intra-articular fracture, you must make the inner surface of the joint absolutely smooth. And usually it is the surgical performance by using of the metallic or different kind of the structures which make the fixation and prevent formation of non-congruent surfaces or non-smooth surfaces after the surgical performance. For extra-articular fractures, that is not so much important because we don't have so big friction, yeah, in the places outside of the joints, yeah. But for the intra-articular kind of the fractures. This is critically important. Remember, please, generally we don't treat intra-articular form of fractures by conservative methods of treatment. That is the rule. Okay, as usually, guys, let's come now to the borders of the region. I will take the chair because we will have a long work here. How we do it? Upwards, you palpated our upper margin of the patella, you put your 3 fingers above it, as I say for femoral region. Yeah? And 6 centimeters or 3 fingers, call it how you want, above the upper margin of the patella, you provided your circular line. That is upper margin. Inferiorly, much more easy, guys. You palpated tuberosity tibia, and immediately in the level of tuberosity tibia, you provided your second circular line. Let's say size of your region will be near the 10 centimeters, yeah? 6 centimeters above the patella and approximately 4 centimeters below patella. Let's say totally it will be the 10 centimeters. Now we provided 2 longitudinal lines. One is along the medial epicondyle, second along the lateral epicondyle, and we divided the region into the anterior knee region and into the posterior knee region. That is easy, I think it's not the problem. Okay. As usually, after description of the borders, let's come to the layers of the region. Make the small topic name, please, the layers of the knee region. And just very few information, the most important I will say, we will write. Right, please, skin anteriorly is much more elastic and movable. Doesn't have many sweat and sebaceous glands. That's why, guys, if you will touch the skin of the anterior knee region, you will see that it is rough.
Yes.
More of these guys, it doesn't have sweat and sebaceous glands. It doesn't have hairs. And this is the general rule for different joints of the human body. Yeah. In the surface of the flexion, because anterior surface it is surface of your flexion. Yeah. Usually we don't have the skin structure as glands or hairs, and that is necessary, guys, to decrease the friction and to decrease the possibility of inflammation of these structures. Compare it with posterior cubital region, approximately same situation. No any glands, no any hairs, yeah, and we have usually dry skin, we have thick skin, we have rough surface of the skin with several folds, yeah, in this region. That is true also for the knee region. Remember about it. Vice versa, from backside, right, the skin is much more elastic, more movable, contains sweat and sebaceous glands. By the way, a lot of the sweat glands. If you make, for example, some physical manipulation, run or don't know, maybe some trainings, you will find that this region is very quickly become to the wet, because the sweat glands is greatly developed here. Sebaceous not so much, but sweat glands is greatly developed in this region. By the way, posteriorly in the knee region, we have also the hairs. It is not so big amount of the hairs, but anyhow, especially for the males, we must mention, because we can see here the inflammation of the hair follicles. Yeah? That is need to be mentioned. Now, right, please, layer number 2, subcutaneous fatty tissue. Anteriorly, it's very badly developed. The more laterally and posteriorly you will go, the better will be developed the subcutaneous fatty tissue. The better will be developed subcutaneous fatty tissue. By the way, attract your attention into this picture. That is not the subcutaneous fatty tissue. How you can detect it, guys? Arteries. Do you see here there are arteries? What does it mean? Proper fascia is removed in this picture. And you see the structures which is located under the proper fascia. By the way, this arterial network, it is exactly collateral arterial network of the knee region. Little after we will draw it, it contains 10 vessels, 10 arteries. So remember, please. But what we have in subcutaneous fat tissue? Right, please, anteriorly. Number 1, it is nervus cutaneus femoralis anterior. You remember it is the branch of the nervus femoralis. Number 2, nervus cutaneus femoralis lateralis. It's located in the lateral side. And number 3, guys, it is nervus saphenous together with vena saphena magna. But here there are one problem, guys. Look to me. In majority of the cases, nervus saphenous together with vena saphena magna little bit turn back to longitudinal line, which is divided anterior and posterior knee region from each other. It doesn't really belong to anterior knee. Vice versa. In majority of the cases, we describe it in posterior knee. But to tell the truth, it's not located immediately in the backside. It's located along this longitudinal line in the level of the medial epicondyle, yeah, which we described before, yeah. But a little bit shifted back to this line. That's it. Don't be confused, guys. Then we describe nervus saphenous and vena saphena magna. We say that mainly this belongs to posterior knee region, but in reality it is in the medial surface. Yeah, it is not in the back, not in front. It is in the medial surface of the knee region.
Yes.
Is it understandable for you? By the way, open the brackets and write, please. Nervus saphenous here, located a little bit superficially, and more laterally to the vena saphena magna. Now, mainly attention to me, guys, how we will project these structures. Previously, as you remember, vena saphena magna, we projected in the thigh region.
Yes.
Yeah? Now we must project it in knee region together with the leg region. Now, write and remember both these structures projected by imaginary line, which is connected midpoint of the medial epicondyle with anterior margin of the medial malleolus. Midpoint of the medial epicondyle with anterior margin of the medial malleolus. Okay? Yeah. That is projection of these structures and in knee region and in leg region and partially also in the foot region, yeah? Because in the foot region they come to the anterior margin of the medial malleolus. By the way, guys, sometimes it is confuse you. In the leg region and in the ankle joint region, it will be located anteriorly. Yeah, so you can see that in knee we describe these structures. In the back, in thigh, it is anterior structure. In leg and in ankle joint region, it is anterior structure. But in the knee region, we describe it as the posterior structure. Keep it in your mind, remember about it. Continue, please. In the fatty tissue of the posterior region, also we describe nervus cutaneus femoralis posterior. Again, it's not news for you. You know about it, we spoke about it. Decide which conclusion we can make. Guys, all skin structures or superficial structures of the thigh region will be descended into that, and we will find them also in the knee region. Also open the brackets and write, please. Here we have the synovial bursas. Little after I will describe for you these synovial bursas. We have the synovial bursas. But now continue and write, please. Structure number 3, it is superficial fascia. No any specificity generally. Superficial fascia. Structure number 4, deep to it. It is the tendons of the muscles, which is come from the thigh region. Anteriorly, right, please, it is the tendon of the quadriceps muscle. Right, please, it is split in the knee region into 3 compartments. A medial one we call retinaculum patellae medialis. Lateral one we call retinaculum patellae lateralis. And middle one we call the proper ligament of the patella. Retinaculum patella medialis, retinaculum patella lateralis, and middle one, it is the proper ligament of the patella. Minute attention into the picture, please. You can see the quadriceps muscle. This is the rectus femoris, yeah, which is the most superficial one. And inferiorly, you can see that it's split into 3 compartments. One is fix the patella from medial side, another fix the patella vice versa from medial side, another fix the patella from lateral side, and one middle one descending to down, come to the tuberositas tibia and fix with the tuberositas tibia and forms the proper patellar ligament. You can see the middle compartment of it. Let's say keep it in your mind. Remember, please, anteriorly under the proper fascia, we have the tendons of the quadriceps muscle, which is split here into three compartments. Right, please, in the medial side, under the proper fascia, we have the pes ansarinus. In the brackets, right, please, it forms by the tendons of musculus gracilis, musculus sartorius, together with semitendinosus, semimembranosus. Gracilis, sartorius, semitendinosus, semimembranosus. Minute attention in the picture, please. This is the medial side, as you can see, of our picture, and this is the pes ansarinus, or pes ansarinus major, call it how you want, and you can see the four muscles here. It is the tendon of the gracilis, tendon of the sartorius, tendon of the semitendinosus, semimembranosus. Open the brackets, right, please. All these structures fused with the anterior medial surface of the tibial bone, anterior medial surface of the tibial bone, and they have practical meaning like the surgical landmarks. In the future I will mention it for you. In the brackets, right, please, to make the access to the fossa popliteal. We'll use these structures in the future to make the access to the fossa popliteal. Right, please, laterally, under the proper fascia, we have the tendon of the biceps femoris muscle. So you can see, guys, forever under the proper fascia, we have the tendons. Anteriorly, medially, and now laterally also. Tendon of the biceps muscle. So you can simply palpate it, guys. This is the biceps tendon. That is the tendon of the pes ansarinus, yeah, which I mentioned.
Medially now.
Now continue, please. It is descending to down. Come to the head of the fibula. Fuse with it. And continues to the gerdis tuberositas of the tibial bone, and also connected with this structure. Let's say it fused not only to the fibula, but to the tibia primary. Let's say, once again, we describe the structures that are under the proper fascia. We have the tendons, which is fused with the bones of this region. Now open the brackets and write, please. The mentioned tendons have the descending direction. They come from the thigh region into the knee region. But under the proper fascia, we also have the descending tendons, which is from knee region goes to the leg region. Once again, this is descending tendons, which is come from the thigh region to the knee region. But also we have descending tendon, which is come from knee region to the leg region. In the brackets, write, please, this is the tendon of posterior leg muscles. Tendon of the posterior leg muscles. In the brackets, write, please, musculus gastrocnemius and musculus soleus. Together they forms musculus triceps surae, as you remember. Yeah, gastrocnemius and soleus forms the triceps muscle of the leg. Open the brackets and write, please, the medial head of the gastrocnemius. Medial head of the gastrocnemius fused with the medial epicondyle of the femoral bone, and head of the tibia. You can see here the gastrocnemius muscle, medial head, and the lateral head. Lateral head consequently connected with the head of the fibula, and lateral epicondyle of the femoral bone. 1 minute attention in the picture, guys. That's how you can see, then you look from the back side, you see 4 tendons, 2 descending from thigh region to knee region, 2 descending from knee region to the leg region. From upwards, medially, you can see the pes anserinus, the 4th structure, as you can see, descending to down. Laterally, you can see the biceps muscle. If you will look to downwards, you can see medial and lateral head of the gastrocnemius muscle. Little deep to them, we have the musculus soleus. Together they form the tendons fused to each other. This is triceps muscle. If the tendons is joined to each other, we call it triceps, means one muscle. Yeah. That's it. Together, as you can see, they forms the diamond-shaped fossa. 2 upper located tendons and 2 lower located tendons forms the diamond-shaped fossa. Write it, please. Under the proper fascia, between mentioned tendons, we have the diamond-shaped fossa. We have the diamond-shaped fossa, which we call fossa poplitea. Fossa poplitea. In the brackets, right, please, borders upper medial one, semitendinosus, semimembranosus. I don't say here gracilis and gracilis together with sartorius. Why, guys? Because they will be much more anterior. Let's say from pes anserinus, last 2 muscles immediately will form the margin of this fossa. Another 2, as you can see, will be a little bit more located anterior. Sartorius and gracilis forms the pes anserinus, but it doesn't involve information of the fossa poplitea immediately. Okay? Let's say laterally, superiorly, it is of course tendon of the biceps femoris. Inferiorly, consequently, medially and laterally, it is the gastrocnemius. Yeah? Caput medialis, caput lateralis. 1 minute attention, guys. From the surgical point of the view, that is the most important compartment of the knee region. Let's say here, open the brackets and write, please. This fossa contained deep, loose connective tissue space. Deep, loose connective tissue space. In the reality, guys, of course, it is osteofacial compartment, not interfacial space, but osteofacial compartment. Why? Because we have more than one bone. Yeah, here, as we mentioned before. Yeah, we have 4 bones in this region. Yeah, and in the brackets, right, please. Here we have the mean neurovascular bundle of the knee region, from medial to lateral, and from in front to behind, from medial to lateral, and from in front to behind. It is presented by 3 structures. Number 1, arteria poplitea, the most medial and anterior structure. Number 2, vena poplitea, located laterally and a little bit superficially to the artery. And number 3, nervus tibialis, the most lateral and superficial structure inside of the fossa poplitea. Now, minute attention in the picture, guys. You can see these 3 structural units from medial side to the lateral side. That is the artery, popliteal vein, and consequently the nervus tibialis. Let's say keep it in your mind, remember. Now let's make the review. My dear friend, you first of all, can you remind me which artery is it, the popliteal one, and how it is become to this region, to the posterior knee region? Along of last 2-3 years, you study this during your anatomy cycle, then in our top anatomy last lessons. So I think you must be more than ready to answer into this question. So this is continuation of the femoral artery. Now remind me please, how from thigh region it's become to the posterior knee region? Right, just last lesson is about this, and we draw even together the pictures, yeah? We mentioned, we show it. How? Because femoral means in the thigh. But we see that from the thigh it is come to the posterior knee region. How this transition is happening? Maybe you believe. How from the thigh region femoral artery become to the posterior knee region? Oh, friends, that's awful. This is my just previous lesson, which I totally give you and say study. We make all the necessary pictures, all necessary descriptions of the matter. Who can answer? Of course. Which canal? Hunter's canal. How we call it in another way, which is showing exactly this direction.
Popliteal canal, femoropopliteal canal.
We call it femoropopliteal because it's connected femoral region together with popliteal fossa. My dear friend, you please just stand up. Please do not look to your equipment. Can you describe me formation of this canal? Yeah, the femoropopliteal, or you can call it Hunter's canal, or you can call it, by the way, adductor's canal. All these names will be useful. Please.
So from one side it is bordered by adductor longus muscle.
First of all, can you come here? Thank you very much. Now stand up by the face to your friends and show, please, by your finger where is located this canal. No, it's awful, dear. The canal which is connected thigh and knee region located No. This canal doesn't start here. Don't say anything which doesn't connect it with my question. I ask you about adductor's canal or femoropopliteal canal, not more and not less. Put your finger immediately in the place of location of this canal, please. Very well. Very great. That's what he showed for you guys. Medial surface of the inferior thigh region. Here. Can you tell me why this canal is called the Hunter's canal?
Because first, whenever hunters go for the hunting, so their gun ending was put in their ear.
Of course.
They have.
And that place can be chronically inflamed, guys, because that is the normal activity of these peoples in the previous times. Why not? Today also it can be happening. That's if we have traumatization of the medial surface of inferior third of the thigh region, we can have inflammation of inside of the canal. By the way, it gives the clinical problem which is called the tunnel syndrome. What does it mean? If inside of the canal we have inflammation, pressure inside of the canal is increased. Vessels and primary nerves irritated inside of the canal, and they gives the chronic pain. Remember about it. Due to the irritation of the, by the way, which nerve we have in this canal? Inside of the adductor's canal, or inside of the Hunter's canal, or whatever you want to call it. Is it necessary for you to make the chewing during the answer? If you even will put your fingers here and will make the pressure, you will feel the pain. As we feel the pain, then we damage the medial surface of the cubital region. Here, ulnaris is irritated. Here's some another nerve. Which one? Huh? Awful. Ischiadic was located inside of this canal. By the way, guys, this is the real and the last and most useful form of the lecture to make the interactive communication to each other. Otherwise, guys, look, I will just speak and you will just sleep. Nervous?
Cutaneous femoralis medialis.
No, of course no. Nervus cutaneus femoralis medialis, guys, doesn't exist. Huh? Who can help you? Which nerve is located inside of this canal? The longest branch of nervus femoralis. Saphenous, of course, then. Saphenous. Why this saphenous? Sit down. Why this saphenous, tell me please, we don't see inside of the posterior region, in fossa popliteal? We say that this canal connected the thigh region with the knee region. And we say that content of this canal from the thigh region by this canal will come to the knee region. Yeah? Femoral artery, femoral vein. By the way, here we will rename and call them popliteal. But where is the saphenous here? What? We lose the saphenous. Why it's not appears here inside of the fossa popliteal? What has happened with the saphenous? I know, but why it doesn't come to the, look there, you are fossa popliteal, I am the thigh region. We connected to each other by the canal. Inside of this canal, we have the femoral vessels together with nervus saphenous. Femoral vessels from me come to you and appears inside of the fossa popliteal. Here we rename the vessels and call them popliteal. What is happened with nervus saphenous? Why it's not appears inside of the popliteal fossa?
Look at it deeply.
Sorry? 2 minutes before I told you that saphenous together with vena saphena magna localized along the line which is connected medial epicondyle with the anterior margin of the medial malleolus. They say God's know how nervus saphenous leave this canal, doesn't come to the posterior knee region, but appears in fatty tissue on the medial surface. How it's happened? How? Question for everybody, guys. How it's happened? If I have tube between me and you, and inside of this tube we have some structures, sure that they will come from me to you, yes or no?
Yeah.
Because we have just one communication. But from these three structures which is inside of the tube, two is reach you, one no. How it's happened? Two it is vessels. Vessels from me come to you. And inside of your region, we rename these vessels. Instead of femoral, we call them popliteal. But what is happened with the nerve, which is with vessels located inside of the canal? What is happened with the nerve? Oh, friends. That is very sad. That is awful. What has happened with the nerve? Sorry?
It is perforated the canal and
It doesn't perforate it, dear. This canal has not 2 rings, but 3 rings. 3 rings. If I will modulate it, just the tube between me and our friend, tube has 2 rings. Now let's imagine that in anterior wall of this tube, also there are aperture. And through this aperture, our nerve will leave the canal and will come to the fatty tissue. That's why finally, to final destination, which is knee region, will come only vessels, not the nerve. Because before final destination, nerve will leave the canal. And nerve will come to the fatty tissue. Why we call? Tell me please, how we translated this term saphenous? What does it mean? Saphenous. We have saphena veins, magna, parva. Now you see saphenous nerve also. What does it mean?
superficial.
Sorry? What does it mean? Huh? You speak with me in that way. Superficial, subcutaneous. Yeah, really. It is superficial and subcutaneous. That's why it disappears inside of the fatty tissue to supply the skin. Don't forget, guys, that for medial surface of the thigh region, in each third, we describe different innervation.
Yes.
Hey, friend, don't sleep, listen to me. Upper third 3, middle third 1, lower third 1.
Yes.
Upper third it is ilioinguinalis, iliohypogastrica, ramus genitalis, ramus femoralis, nervi genitali. Middle one it is the skin branch of obturator, and lower third it is nervus saphenous. So remember, guys, it's not hard. Saphenous come to fatty tissue by anterior ring of canalis adductorius or canalis femoropopliteae. Remember, it doesn't enter inside of the fossa. Now we need to pay attention again into the fossa. Let's now discuss content of this fossa. Neurovascular structures, from deep to superficial. It is the artery, it is the vein, and nervus tibialis. What is nervus tibialis? You don't have it in entire region, but you have nervus ischiaticus. As you remember, it is located in posterior femoral groove. We draw it together between semitendinosus membranosus from one side and biceps femoris from another side.
Yes.
We have posterior femoral groove. And inside of this posterior femoral groove, just in the level of the upper margin of the fossa popliteae, nervus ischiaticus, this huge yellow structure, split it into 2 terminal branches. One is located more medially, second laterally. By the way, second branch doesn't enter inside of the fossa. As you can see, it is just slide along the lateral margin of this fossa and come to the anterior lateral leg region. Let's name these branches. Medial one we call tibialis, lateral one we call peroneus communis. That's it. Remember, please, these 2 branches, nervus ischiaticus, near the upper angle of your fossa popliteae, split it into 2 terminal branches. Medial one we call tibialis. It's involved inside of the neurovascular bundle, together with popliteal vessels. Lateral, no. It's not just not included inside of neo, but it doesn't enter even inside of fossa popliteae. It is slided along the biceps tendon and come to the anterior lateral leg region. Immediately in anterior lateral leg, guys, in the level of the head of the fibula, between tendon of the long peroneal muscle and head of the fibula, it is entering into one more canal. That's it. Imagine she is head of the fibula, I am the tendon of the long peroneal muscle. Between us we have the canal, which is called musculoperoneal superior, because we have musculoperoneal inferior one also. Inside of this canal, this nerve, lateral one, which we call common peroneal nerve, it is split into 2 terminal branches. Peroneus superficialis and peroneus profundus. Remember, please, this division. That's like nervus ischiaticus split it into tibialis, peroneus communis. Tibialis entered into fossa popliteae together with popliteal vessels forms the neurovascular bundle. Peroneus communis slided into the leg region, along the biceps tendon, enter into the canalis musculoperonealis superior, split it here into 2 terminal branches. Peroneus superficialis, peroneus profundus. After in the leg region, both these nerves we will see. By the way, peroneus profundus, after this, come to the anterior osteofacial compartment and forms the neurovascular bundles together with tibialis anterior vessels. Tibialis anterior vessels. Peroneus superficialis, innervated peroneal muscles, then come to the skin and innervated skin. Look so, we can say, symmetrical or so same in structures in upper and lower extremity. Do you remember in upper extremity, nervus muscular cutaneus? It's also, as you remember, partly innervated muscles, partly innervated skin. Here the same function has the peroneus superficialis. In upper and middle leg, it's innervated muscles, peroneus medialis, peroneus longus and brevis. In lower third, it is innervated skin. Let's say we can say that this is mixed nerve. Is it understandable for you? By the way, in the future, all these structures together will all be squared. Now write please, projection of arteria poplitea and neurovascular bundle. Imaginary line between upper and lower angles of the fossa poplitea, very easy. Imaginary line between upper and lower angles of fossa poplitea. Now write please, surgical access to vessels. Number one, posterior access along the projectional line. In the brackets write please, not so much useful because during excess formation you can damage the main structural units inside of it. Number two, through the Jober's fossa, or in the brackets write please, medial access. In the brackets write please, it is between tendon of medial head of musculus gastrocnemius, tendon of medial head of musculus gastrocnemius, and the medial condyle of the femoral bone. Condyle or epicondyle, call how you want, no any difference. Now look to me. You palpated the gastrocnemius, you find the medial head of it, and you also palpated the medial epicondyle of your femoral bone. Immediately between them, greatly palpatable, there are depressions. Yeah. So from one side it is medial head, from another side it is the femoral bone. And from that fossa, much more safely, you can make access to artery. Why it's much more safe, guys? Because you come to the medial side, medially to artery, we don't have any other elements. Elements located or superficially or laterally to the artery. It's like this access is much more protected, comparable with the posterior one. One more sentence, right, and we will continue. Inside of the fossa poplitea, big superficial vein, which is called vena saphena parva, perforated the proper fissure, come to the fossa, and drain into the popliteal vein. It is perforated the proper fissure, come to this fossa, and drain into the popliteal vein. Minute attention, guys. In all another lower located regions, you will see this vein, which is called vena saphena parva. Below the knee region, your lower extremity has not one but two superficial veins. Saphena magna will be in the medial side, saphena parva will be in posterior lateral side. How we project it? Look to me, everybody. You take the posterior margin of your lateral malleolus and you connect it with geometrical midpoint of your fossa poplitea. Means the midpoint of the distance between upper angle and lower angle by midline. Immediately in this upper projectional point, the vein perforated proper fissure from subcutaneous fatty tissue become to the fossa popliteal and drain inside of the popliteal vein and finish. That's above the knee region. You don't have this vein. It is absent. Idea is understandable for you guys. Now write the name of small one topic, synovial bursas in the knee region. Synovial bursas in the knee region. Right, please, they decrease the friction during the flexion extension inside of the knee joint, adduction, why not? Together. And they located primarily in the 3 layers. Number 1 in subcutaneous fatty tissue. Number 2 under the proper fascia. And number 3 under the tendon of the muscles. In the brackets, write please. In subcutaneous fatty tissue, we have 3 synovial bursas. We have 3 synovial bursa. Number 1, we call bursa mucosa prepatellaris subcutanea. Prepatellaris subcutanea. Many attention, guys. Prepatellaris bursas you will see in different layers, but all of them projected in the midpoint of the patella. But they can be in different layers. Let's say in subcutaneous fatty tissue, in the level of the midpoint of the patella, we have first synovial bursa. Right, please. Second one we call bursa mucosa subcutanea medialis. Medialis. Bursa mucosa subcutanea medialis. 1 minute attention, guys. We call it also rider's bursa. If you make the horse riding, usually, guys, if you did it, you will know. For example, I have, when I was young, then I ride the horse, inflammation in this bursa. Why? Because it is chronic irritational place. It is located just in the level of the tendon of the semimembranosus. And during the ridings, it is chronically irritated bursa. That's why we call it rider's bursa. It's located in the medial side. Is it understandable for you? And right, please, finally, the last one, it is the bursa mucosa infrapatellaris subcutanea. Infrapatellaris means near the inferior margin of your patella. That's why in fatty tissue, we have 3 synovial bursas. Continue, please. Next layer, it is under the proper fascia, just only 1 synovial bursa. Again, it is prepatellaris, but now subfascialis. Prepatellaris, subfascialis. And last 3 bursas located under the tendon of the quadriceps. Again, right, please. First one, it is the prepatellaris. We call subtendinea, means under the tendon. Second one, infrapatellaris, subtendinea. And last one, suprapatellaris, subtendinea. For this last one, guys, open the brackets and write please. From the 7 mentioned bursas, this is the single one which is communicated with the knee joint. So inflammation from that last one can be spread from the bursa into the knee joint structures. That's why from bursitis we can achieve the arthritis, inflammation of the knee joint. Write please the next topic, and we will make now the picture and call it please the collateral arterial network of the knee region. And point number 1, write please, all collateral vessels, arteries, localized under the proper fascia. In the brackets, write please, between proper fascia and tendon of the muscles. Now I will try to put this into the drawing mode.
Sir, on the white circle.
How to can
White.
you come and help me guys? Just put the white.
अशी बोर्ड पाहिजे बोर्ड.
Thank you very much. It's good. Then, thank you very much. Let's choose again the right extremity. Let's say here I will put M.
Eraser. Sir, take eraser.
Don't worry, no problem. Here I will put L, M and L. Let's draw from upwards our femoral bone by two epicondyles. From downwards, medially, let's draw the tibia. And from lateral side, draw the fibula. I don't need here the popliteal. Let's say popliteal is not important for me. Sorry, patella. I don't need it, just the structures which we have here. Okay, I think it is understandable, recognizable for you. Now let's change the color. Let's take the red color. By the way, as you can see, guys, I show for you picture from in front. But the main artery, of course, located behind. Let's say now along the femoral bone, I will draw big intraptid line, which is descending to down. And here put please the number 1, number 2, and call please number 1 we call the femoral artery. By the way, upper part of artery 1 make non-interrupted. 2 is made interrupted. And then, in the border between the femoral and tibial bone, divide please artery 2 into 2 terminal branches. One I draw by non-interrupted line, and second I draw by interrupted line. Put the numbers, please, number 3 for non-interrupted, and call it arteria tibialis anterior. And number 4 for interrupted, and call it arteria tibialis posterior. Before I will continue my picture, guys, remember forever, please, your popliteal artery, inferior angle of the fossa poplitea, split it into 2 terminal branches. One we call tibialis anterior, second we call tibialis posterior. What does it mean? Now, I will show you in our example. Let's imagine that me, together with our friend, we are 2 bones of the leg region. I am the tibia, and medially located, she is the fibula. You know that we connected to each other by the membrane, interossal membrane, which is connected us to each other. Upper portion of this membrane between our 2 bones is perforated. And tibialis anterior artery, by this perforational aperture, from the posterior knee region, become to the anterior leg region. In the future, we will draw this. By the way, in the level of the inferior angle of the popliteal fossa, one more canal will be formed, and we will call it the cruropopliteal canal. You remember before we described femoropopliteal canal. Now we will describe cruropopliteal. Crus, it is leg region. This is the canal which is connected posterior knee region with the leg region. By the way, by the author we call it Gruber's canal. Let's say cruropopliteal canal or Gruber's canal. Very resemble structurally, I mean by the apertures, by the meaning of apertures, very resemble to the femoropopliteal one. As femoropopliteal, it has not 2 apertures, but 3 apertures. It has, of course, 1 entrance
2 exits.
and 2 exits, like our Hunter's canal. And immediately now I describe for you anterior exit, which is located in the interossal membrane. and by which the anterior tibial artery from posterior knee region become to the anterior leg region and forms the neurovascular bundle here. By the way, second branch we call posterior tibial artery. It is just pass inside of the canal from up to down. And finally, guys, it is enter into another canal. It is located here. I put now my finger between my Achilles tendon and my medial epicondyle. This canal we call canalis malleolaris. What is conclusion? Gruber's canal, by its inferior exit, communicated with malleolar canal. And arteria tibialis posterior, together with nervus tibialis, finally come to the malleolar canal. All another history I think you know very well from your anatomy. Inside of the malleolar canal, these mentioned structures divided into two terminal branches, plantaris medialis, plantaris lateralis. Let's say tibialis posterior artery supply the plantar surface of the foot. Tibialis anterior one continues to your dorsal foot region. And here we rename it and call it arteria dorsalis pedis. Of course, in the future we will draw, we will describe all these structures. But now remember this picture. Let's say, if I will take here, for example, blue color, we can mention these. We can mention these popliteal fossa, approximately in such a way. And you can see that near the inferior angle of this popliteal fossa, our artery number 2, which is called the popliteal artery, split it into two terminal branches. By the way, in this picture, guys, interrupted structure, look, I little bit make not correctly, because to tell the truth, I must to draw here by interrupted line anterior structures, yeah? By non-interrupted line posterior structures. Let's say, if it will be so, number 3 one will be tibialis anterior, number 4 one will be tibialis posterior. Because again, I say you, I show a picture from in front. Is it understandable for you? Let's say just change the names. Yeah, third one is anterior because it's non-interrupted. Fourth one, it is posterior. But again, guys, this third and this fourth, both is originated in back. Third one also comes from fossa poplitea to the anterior leg region because it's originated in the back. Is it understandable for you guys? Very well. If you understand it, let's continue, guys. Now look everybody here. One more non-interrupted red line I will draw in the lateral side. And I will descend it up to the lateral epicondyle of the femoral bone. Put the number 5 here and call it ramus descendens arteria circumflexa femoralis lateralis. Ramus, hurry up guys, time is short. Ramus descendens arteria circumflexa femoralis lateralis. You can see that forever it is non-interrupted. It means anterior structure. Meaning tension, guys. My dear friend, you for example, can you remind me what does it mean, this ramus descendens, where it is originated, and how it is come to our region? I think you like to be confused forever, guys, in your life. That is the usual your situation when I ask you anything. Do you appreciate it? So why you don't change this situation? Why you don't start to work? I think it's like the masochism, you know, you appreciate it to being confused. I cannot call it in another way. Why you need to look now to my face there? Can you tell me? That's strange. Maybe you, dear. What does it mean, this artery? Where it is originated?
From deep femoral
How
artery.
it passed? Yeah, how it became to this region? Where is the place of its origin? Ramus descendens, circumflexa femoralis lateralis.
From deep femoral artery.
Friends, now look. From the first minute up to the last one, I speak, I describe. But I want also to be necessary for you. Because we have necessary work and we have unnecessary work. I don't want to make unnecessary works, guys. I want to be really helpful and really necessary for you. But sorry, then I come after my explanation, ask you some questions and don't see any result of my previous work. I make conclusion that I'm unnecessary. So how is it possible? Guys, we draw together all these pictures, sections. I don't just only explain for you. I visualized all these problems. Who can explain me? Who can remind me where they originated and how it passed? Now, guys, open your pictures, which we do before.
Origin.
Do you have the cross pictures?
We did have your class last week.
We didn't have the class too, but before my lecture, I ask you, am I finished the cross sections? And you say yes. I ask you, say, guys, before start my lectures, I come and say, friends, am I finished with you the femoral region cross sections? You say yes. What?
We came late, sir. I don't know.
Once again, I ask you guys, am I give you cross sections of
For 301 you gave, for 302 you didn't teach.
You say, friends, why you don't inform me about it? Then I ask you.
We don't know what.
It's strange. I ask to all my auditory, am I finished it or no? You say yes. Many attention to me, guys. To answer, don't draw now what I will draw, just look to answer into that question, what is this artery? I must to draw, first of all, for you,
Deep
our
Deep femoral artery.
femoral region. Because this is, we choose together, guys, the left extremity. I also draw you, how I can say that this is left one. That is medial side, yeah? This is medial. Let's say for the left one, this is medial side, that is lateral. For right, vice versa. This is medial, that is lateral. So left extremity, that will be our inguinal ligament. And if I will remove the skin, superficial fascia, and superficial layer of the proper fascia, immediately below this inguinal ligament, I will see the triangle. This triangle, guys, we call the femoral triangle. Hanarca. What's up? Bana bekleriz. Kamerası este sondalıcı. Entonces, superficial layer of the proper fascia. One group know it very well. And you see this triangle. This is, guys, the upper third of the medial interfacial space.
Yes.
As you remember, in the cross sections of the upper extremity, we also draw these interfacial spaces. Now, for the lower extremity, again, skin and fat is removed here, guys. Proper fascia gives intermuscular septus, which is attached to your femoral bone. By the way, if in upper extremity we have two intermuscular septa, in lower extremity you can see three.
Posterior didn't.
By the way, posterior, I make the mistake, it
Didn't
doesn't
touch,
touch
yes.
to the bone, only medial and lateral. This space which you see now in the
Interfacial
picture,
space.
space A, it is the same this
Femoral.
triangle in the upper third.
Yes.
Then you look from in front, it has triangular shape form. Then you look in the cross section, it has the intermuscular septal form.
Yes.
And inside of this space, along of all thigh region, we have the main neurovascular bundle. Remember, please, upper third of this space we call the femoral triangle.
Yes.
Middle third
Anterior
we call
femoral
anterior
groove.
femoral groove.
Adductors
Lower
canal.
third we call
Adductors canal.
or we say
Femoropopliteal canal.
What is located along of all thigh region inside of this space? Femoral artery,
Femoral vein.
vein. Look, I don't say femoral nervus. Because femoral nerve finish in upper
Upper
third.
third.
In the middle and lower third,
Branch.
it was absent. In upper third, it gives a lot of branches. Partly skin, partly muscular, but the longest branch we call nervus
Nervus saphenous.
And in middle and lower third, it passed together with femoral vessels. Now, why so longly I spoke about it? Because femoral artery, by the way, if I will draw here, the structures will be vein, artery, and nerve. And as you can see, guys, nerve, I split it into terminal branches. Let's say V, A, N. And what about A? A gives here one deep branch,
Deep femoral
which
artery.
goes behind the artery,
Deep
and
femoral
which is called profunda femoris.
Yes.
And immediately this profunda femoris gives two
Medialis.
surrounded femoral bone arteries.
Lateralis.
Circumflexa medialis, one, and circumflexa
Lateralis.
lateralis. Each of these circumflex arteries
Ramus.
split it into
Ascendens
ascending
and
descending.
descendens.
Ascending and descending. And artery number 5, which I draw now for you in the picture, it is exactly descending branch of circumflexa femoralis lateralis.
Yes.
But let's continue, guys. Look in the picture, please. One more artery. I will start it in the lower third of the thigh region, and with non-interrupted line, I will descend it into the medial surface of our knee region. I will put here number 6. And call it, please, arteria genu descendens. Arteria genu descendens. Hurry up, guys, time is very short. Arteria genu descendens. What is it, guys? Now, again, attract your attention to me. Now, let's completely draw this thigh region up to the knee. This is our knee region. So look to me, guys. This is triangle, okay? This is a groove, okay? And that is canal. That is canal. That's why you see, guys, I draw 3 compartments. First, second,
Third.
and third. All these compartments belong to the medial interfacial space. Upper one we call femoral triangle, middle one we call
Anterior femoral groove,
and lower one
adductors canal.
You remember he also showed you? It is the
Adductors canal.
or Hunter's canal or femoral popliteal canal. Call how you want. Can you give me one paper? Thank you very much. Now let's make the canal. Let's imagine that this is my femoral. Can I draw something in this canal? In this paper, do you need it? No. I will draw just one more ring. Now, if I will form now a canal, it will immediately, guys, show for you apertures. Look, one, it is entrance. 2 others, it is exit.
Exits.
This one we call anterior exit. That one we call inferior.
Inferior exit.
Inferior exit, guys, connected your thigh with your knee region. Inferior exit provided femoral vessels. Look. Not so good reaction. Providing the femoral vessels into the posterior knee region. That's why the canal we call
Femoropopliteal.
Do you see this one aperture also?
Yes.
Now let's draw. Which color is it? Blue. Black. Super. One black. Is it red? And one red. Look, guys, from this anterior ring, 2 structures leave the canal. Black one, it is nervus saphenous. It's come to the fatty tissue, and after it passed together with saphenous magna vein, do you remember I told you that they passed together, and we even projected these structures, as you remember. What is the artery? You see it here, artery 6. It is gained descendants originated from femoral artery inside of the canal, by anterior exit, leave the canal, and come to the knee region and localize it under the proper fissure. And together with another vessels form the arterial network. Is it understandable for you? Let's continue, guys. That's not all. Now we come to the posterior knee region. And in posterior knee region, guys, I draw two arteries in the level of the upper border of the fossa popliteal. In my picture, it will be 7 and 8. Two arteries in the level of the inferior margin of the fossa popliteal. In my picture, it is 9 and 10. And one artery in the midpoint of the fossa popliteal. It is goes strongly from posterior to anterior. Number 11. Name these structures. 7 and 8 we call arteria genus superior, medialis and lateralis. And 10 we call arteria genus medialis and lateralis. You see, this is horizontal vessels, not descending and not ascending. It is horizontal vessels. And finally, 11 we call arteria genus media. It is supply your knee joint. It goes from back to in front. Is it understandable for you? Very well. Another 3 vessels, guys, another 3 vessels will be ascending. Means will originate in leg region and will goes from leg to upwards. Now look here, please. 2 from these vessels I originated from third one. Third one, it is tibialis anterior. Yeah? Tibialis anterior. One I provided in the lateral side, one I provided in medial side. Put the numbers 12 and the numbers 13. By the way, 13 one also interrupted. Call it arteria circumflexa tibialis anterior, arteria circumflexa tibialis posterior. One is come to in front, second goes to behind. And one more artery, guys, originated from fourth one and come to the lateral side and anteriorly to the head of the fibula. In my picture, this is artery 14. Call it, please, arteria circumflexa fibulae. Circumflexa fibulae. Friends, now let's make a conclusion, finally. Now 10 vessels, 2 descending, 3 ascending, and 5 horizontal. Descending, it is artery number 6 and artery number 5. Ascending, it is artery 13, artery 12, and artery 14. And horizontal 7, 8, 9, 10, 11. All of them together forms the collateral arterial network, which we call network of the knee region. All these vessels located under the proper fissure. Now we need attention, guys. Let's speak about functionality of this collateral network. If I compare it with the collateral network of the cubital region, I see that functionality is lower. What does it mean? If we will have the blockade of the main artery in the region of the posterior knee, collateral network will not be responsible to completely compensate supplement of the lower extremity, and we will have necrotization of it. Experimentally, we find it that it can increase the supplement from 20 up to 35%, but cannot give the 100% compensation. Conclusion, why we need it? Mainly for physiological, sometimes for some pathophysiological, but not complete obstructional situation. For example, not so developed, but atherosclerosis. We need the compensation collateral network provided, or much more commonly, physiologically, you make some physical work, you
Sure.
need the more level of the supplement, collaterals is open and provided some more supplement. But again, I say you, if the mean artery will be closed, they will not make the complete compensation. Forget about it, please. This is what I want to give you today, guys. My time is over. Do you have any questions to me? If no question, let's check quickly our attendance.